So our next section of this day will be drug interactions, and we're going to start off with Dr. Antoine Douaihy, who is Associate Professor of Psychiatry at the University of Pittsburgh School of Medicine, and is Medical Director of Addiction Services at Western Psychiatric.
Thank you. Good afternoon. Thank you so much for those inspiring statements. On behalf of Philadelphia, I can say on behalf of Pittsburgh, we share the same, feelings about it. Okay, well, first of all, just a couple of comments I would like to make throughout the day. And obviously there were great presentations, and great contributions from the audience with the discussion. And we clearly have a consensus in a way when we think about working with patients who are on opioid maintenance treatment and who are abusing different other substances, particularly benzodiazepine, is that we definitely deal with a lot of dilemmas that are clinical, legal, ethical. At the same time, we always need to think about it from what we've been discussing very early on, the importance of the personalized, the person-centered approach, which obviously is really not because we wanted to really utilize this whole interdisciplinary approach, or the whole biopsychosocial approach, because it is what the evidence-based treatment is. So obviously we have a clear obligations, to professional, ethical obligations to our patients and our communities and the families of our patients and their significant others to really utilize the evidence-based treatments that really work. And this is basically a big part of, I believe, what we are really here for, is to eventually come up with some really consensus on what really would be, what we could really potentially define as evidence-based practices or evidence-informed practices that can help us guide, treatment of these patients. So getting into this little bit of a boring, or I don't know, maybe a little bit of a dry topic of the drug interactions here, the one thing I wanted to mention is going to be really brief. I'm not going to overwhelm you with a lot of the details about pharmacological details, but I want to try to really see if I can make it very clinically oriented, and how we can utilize drug interactions in the context of working with patients who are on opioid maintenance treatment as really teachable opportunities, moments that we can have with the patients to really have a conversation about change, and particularly to really obviously make sure that the patients are seeing the effects of using benzos on top of the medications they are on, and what sort of effects they are going through as a result of that, and really utilizing that as a way to really get the patients to start looking at what sort of a change they would want to really make. Okay, so well, I don't want to, this is very briefly, and I want to keep rehashing what's been really already discussed and really been well established here, is that clearly we have more and more, it's been more and more problematic in terms of really the dramatic increase in death related to the methadone use, both for the treatment of pain and illicit drug use. So it's been happening also in the context of pain clinics that are prescribing methadone for pain management. And the drug interactions are significantly implicated in these deaths. And obviously, as we know more and more now, there are concerns over the misuse of buprenorphine and methadone in combinations with other sedatives. And let's not forget also the alcohol that we see very frequently happening in the context of patients who are in methadone programs or patients who are on buprenorphine. So this is what I think would be very helpful to really define clinically what we're really dealing with here. And when we're talking about the effects of the combinations, particularly we're talking about the sedation, and which is really going to be very much of a subjective. We see it obviously objectively, but mostly you're going to have the patients sharing with you subjectively what the effects of being groggy and over-sedated as a result of being on these medications, the combinations of the medications. And this is really significant when we're talking about the impaired the psychological impairment, which is really the motor and cognitive performances. And obviously, as we've talked about it earlier, the impact on the central nervous system and the respiratory system, and obviously the risk of overdose and death. Okay, so again, this is a lot of these things have been discussed earlier. The scope of the problem, in a sense, this is really obviously a big issue, the use of benzodiazepines in the context of opioid maintenance treatment. And just to really, again, this has been also discussed earlier, covered very well in the presentations earlier about the high incidence of co-occurring psychiatric disorders. And again, also these are some of the data that have been also mentioned earlier about the impact of benzodiazepine in the context of really the heroin-related death, or some of these studies that have looked also like around 40 to 80% of methadone-related death are related, in fact, to the benzodiazepine combination. So here, the little bit of the raw materials in terms of the drug interactions. I believe a lot of people would know about that context. I know a lot of the medical trainees are familiar very much with the cytochrome P450, the enzymes that are responsible for the metabolism in the liver of a lot of these medications, and obviously including the methadone, buprenorphine, and benzodiazepine. The one thing that I want to really emphasize very much on is really when it comes to the context of benzodiazepines in the opioid maintained patient on buprenorphine or methadone is really the what we call the pharmacodynamic interactions that matter the most. What I mean by that is basically how synergistically, how these two medications, including the alcohol, and I want to really forget that, work really on the same mechanisms in the brain that is really end up resulting in the side effects or really the impairment that we see. And particularly in the context of really buprenorphine and benzodiazepine, but also really in the context of also the methadone and benzodiazepine. And we know also very much about, in the context of patients who are on methadone, particularly big doses of methadone, they struggle a lot also with some impairment in their executive functioning, the tasking and everything. And this is why sometimes we really get frustrated with a lot of these patients who are in treatment, particularly in group settings, and they are not learning quickly coping skills, relapse prevention skills, or they are not really processing or applying a lot of these things. And we have a tendency to right away be judgmental about the fact that immediately really interpreting it as they are not motivated enough to change or something. In fact, a lot of these patients struggle with a lot of their cognitive abilities and particularly their executive functionings to learn, and really in the psychotherapeutic process, and really particularly when it comes to the coping skills. So we need to keep that in mind. And when we're adding the benzodiazepine factor to it, it could be much worse. And these are a lot of these patients who are going to end up struggling a lot in treatment to really make changes. And the changes are really, most of the time, the changes they're going to be able to really, in a way, make are really very much interfere. The changes that they would want to make sometimes, they could be very highly motivated to make these changes, but they are not capable. They are not really able to really do it. And we need to keep that in mind from a clinical perspective. And the other thing, as I mentioned, also the impact also on some of the receptors in the brain, particularly with the alcohol, that could also lead to really the overdoses and death. So one of the things, unfortunately, we don't have much really done in the context of a human beings, studies, and little human research that has been done in that context. And there has been always the debate over really the question, and we talked about it, the zero tolerance concept, because some patients could be taking benzodiazepine and doing well in a sense, and not really misusing them or abusing them, and really not being impaired. And so the question is that whether, are we talking about really therapeutic doses and interactions, whether high doses, where we define the high doses, and unfortunately in a lot of situations, clinical situations, the patients are really not necessarily very much reliable, or they are really reluctant to share how much they are using and what ends up really happening. So with these erratic behaviors that we see, particularly when they are under the influence, obviously they can engage in a lot of really the behaviors that result from really an impaired judgment or impaired decision making. So they might really not remember that they have been taking 10 milligrams of alprazolam every day, and they can tell you 5 or 6, well, I'm not sure, might be 8, and so keeping that in mind when we're talking about really also the interactions would happen in the context of whether we talk about really high doses or really therapeutic doses, and how we define that is really questionable too. The other thing is really also with the challenges, particularly clinically, is when you have patients who use episodically, who tell you that they really don't use all the time, they use every once in a while, and then obviously sometimes the urine drug screen is positive, some other times the urine drug screen is not positive. So these are things that could really happen also in the clinical setting. So just very briefly and very importantly, before I really finish up quickly here, is what I mentioned basically is the two significant effects, the subjective effects and the psychological performance effects. The subjective effect, as I mentioned, could be a lot of patients telling you they feel like their heart is racing, even in changes in the blood pressure, what we call sometimes the oxygen saturation. So patients are not really are exhausted, and so they present really objectively that they are not in good shape, and also subjectively they can tell you they are not functioning well. And the other thing is the psychological performance. And when we talk about psychological performance, this is something we can discuss with patients, that most of the time they are not necessarily aware of really the impact, is basically impairment in terms of the driving skills. I know it was mentioned earlier, the driving skills, employment, the tasking, parenting skills, when it comes to engaging in risky behaviors, whether injecting drugs and sharing needles. So a lot of these things could really be potentially affected when you have patients using benzodiazepine on top of being on methadone or buprenorphine. So again, as I very briefly here, what we're talking about really also, particularly it becomes more and more problematic with people who are using it for really the long run, and people who are using high doses. So to finish up here, the clinical implications, as it's been already discussed earlier, is that it's always important when we have patients who are abusing benzodiazepine in the context of opioid maintenance treatment, is to make sure that we're integrating the treatment. We're not really looking at basically some of the approaches. Unfortunately, some of the traditional approaches is really, some programs that we've seen really doing sometimes is basically trying, many the interventions, and the interventions not working, and reaching a point where they get very angry, frustrated with the patient, and really reaching a point where we decide, look, we can't anymore provide you with anything, and we're going to have to really discharge you. And we've seen people really being kicked out from really the treatment programs for the same reasons they were admitted for. And this is still happening. We're doing way better compared to 10, 15 years ago, but we're still not really there when it comes to really this understanding, and how we can really, how can we really juggle the whole idea of harm reduction in the context of, we want to make sure, obviously, we're not really enabling any particular behaviors at the same time. We want to remain therapeutic. So these are some of the clinical dilemmas that we deal with, and this is why it's so essential to really get everybody who's involved in the patient's treatment together and brainstorm with the patient on different approaches to really figure out what could be really done. And one more thing here is that I want to mention is that we've attempted a lot of also the interventions in our clinics, and what we're going to be trying to do here is something has not been mentioned earlier, the motivation incentives. We're going to be basically starting a project in our clinic. We've done it with cocaine, with the cocaine dependence piece, because in methadone treatment programs, we have a lot of patients who abuse cocaine, is to look at motivation incentives as a way to keep patients engaged in treatment, and also to really have hopefully some impact on the drug use outcomes. Thank you. I think we can take a couple of questions, comments.
Thank you very much. I actually have two questions.
Yes.
You mentioned cytochrome 3A4. Mm-hmm. Does that enzyme metabolize both the opiates as well as
the benzos, some of the benzos?
Okay. The reason I asked the question is I had read research where benzodiazepines, because there's a competition for the enzymes, can actually increase the blood plasma level of methadone.
Yes.
Is that true?
Yes.
Okay.
No, but again, a lot of all these things are really very much in vitro that we know from, and I think mostly in the context of the buprenorphine and the methadone, we see more of the pharmacodynamic interactions that I mentioned that are more worrisome clinically, that are more really significant clinically than necessarily the interactions with the cytochrome P450. But again, it's also really related to what other medications patients are on. I mean, we see it, for example, in the context of patients who are HIV positive and a lot of the antiretrovirals, you have more drug interactions. So I didn't mention much about that, but most of the patients that we have in treatment, they are not just on buprenorphine and using benzos, but they also could be on antidepressants, other medication, antipsychotics, and all these things could really potentially become more problematic when it comes to the drug interaction and the involvement of the cytochrome P450.
Okay, and that actually leads to my second question. You mentioned the pharmacodynamics, because the opiates work at the opiate receptors, and benzos are working at the GABA receptors. At what point do those two systems interact?
Well, they do interact. And they can obviously it's really what we're really talking about is also what the interactions are really potentiating, because the effects are really the same in a sense. If you're really kind of looking at, for example, with the sedation piece, you can really see it from both in a sense. And they are really very much intertwined. The glutamate is another one that is very much also intertwined with the GABA, with the opioidergic, system. So again, and this is where the alcohol piece, as I mentioned, adds to the whole really problem. And again, keeping in mind that for example, even the small doses of really the benzos in the context of a little bit of alcohol, on top of it, the methadone could also really potentiate all these systems in the brain that could really, in people who are really more sensitive than others, that could really lead to really serious effects, and particularly whether the excessive sedations, impairment, or even overdose.
Thank you.
Sure. Yes.
I'm a psychiatrist at a methadone clinic, and over the years there, I have referred quite a few patients for sleep lab testing. And I have a clinical impression, without any real evidence, that there is a high incidence of sleep apnea among that population. And so I think if we're presented with someone who has chronic sleep disruption and various non-narcotic sleep aids don't help, and they're exhausted and they want something, especially considering the risk of mixing benzos with methadone, which would be increased in a clinical situation of sleep apnea. That referral for sleep lab testing, I don't know how common that is, but do a lot of it at the
I think that's really, we do see that, and I think it's the fact that you really always, because a lot of what sometimes we want to interpret the fact that they have sleep disturbances right away, that because they are using substances or because of what medications they are on, without really thinking what could be other reasons why people have really sleep difficulties. And I think always keeping that in mind, that if you have some suspicion that there could be other like sleep disorders or any sleep apnea, for example, and referring them for specialists, would be really very much helpful. You raised the issue of what would you do, particularly with patients who experience, which I believe 80 to 90% of patients who are on really methadone, on opioid maintenance, or who are abusing other substances or even having other addictions, they have sleep problems. Disruptions in the sleep. It's like, what would be really the safe medications to use in that context? And unfortunately, when it comes to really the studies that we have, it's really dismal. There is not much really that has been done in that context. Obviously, using what we've been really using a lot is, obviously, we rely a lot, for example, on the trazodone. We rely a lot on mirtazapine, the small doses. We rely sometimes on the hydroxyzine, the mild anti-anxiety. And so we tend to really kind of go with using some medications that are really safe, that might not really obviously normalize the sleep completely, but at least it could really help somewhat. But obviously we know very well, if they are not really using episodically or intermittently any other substances, particularly alcohol also, that could be very problematic in that context, that the sleep, they can tell you their sleep pattern improves, but it will take obviously time. And keeping in mind, unfortunately, there are a lot of practices that have been happening out there that use very much inappropriately some medications, for example, quetiapine, to really help with sleep. And a lot of people, obviously a lot of patients would come and really tell their physicians, well, look, somebody else tried, quetiapine, and can you give me 50 milligrams? Can you give me 100 milligrams? And we need to really be careful about not really engaging in any practices that are really not appropriate, not clinically indicated, and not safe necessarily, particularly in that populations, as you know, also with the context of drug interactions, the QTC prolongations, issue, with the heart problems that could really be the result of really being on quetiapine and methadone and all these things.
Yeah, but I think when you're considering possibly maintaining someone on a moderate dose of a benzo because of chronic sleep difficulty that nothing else works for in a treatment setting of
But
methadone,
I think you have to
then a
yeah.
referral for sleep lab testing should really be part of
Yeah,
the
I mean,
evaluation.
I think, as long as you have really a good clinical indication and you have a clear monitoring of this, I mean, it's a somewhat of a risky practice. At the same time, it could be really done. I think the question is the building tolerance, in the case of really treating, for the sleep, if you might need to really keep going up on the dose that wouldn't really work anymore. So we have to keep that in mind. Thank you.